opportunity to talk about allergology. We are going to talk about allergy testing tonight, and it is always a privilege and it does excite me. So Nelson Mandela said, "May your choices reflect your hopes and not your fears." So let's talk about allergy test choices tonight. The history will guide you what to test. Always try and match the patient that sits in front of you and the choice of test what you are going to do. But why would you want to do allergy testing? Let me put up my allergy hat and let's discuss this. Allergic diseases is a basket of diseases, the same immune tendency but different presentations. So you can have atopic dermatitis affecting the skin, anaphylaxis, the most severe of these allergic reactions. You can have asthma, which can be allergic or non-allergic, allergic rhinitis, allergic rhinoconjunctivitis, as Professor Weinberg taught us, food allergies, insect venom allergy, drug allergy, occupational allergies, which can again be a whole basket in itself. So how do we go about applying allergy testing? Allergic disease is mainly a clinical disease. So if the patient sits in front of you, is this clinical picture that I see and get from the history caused by an allergy, or is it some other immunologic disease, or is it an infection? So we have to listen to the history. If you look at any guideline and any discussion in any allergy journal or allergy handbook worldwide, it will always say that the cornerstone and the backbone of diagnosis of any allergic condition is the history. Listen to the patient. It still is most important. So why would I test and when would I test? Why would I test? To confirm the diagnosis. Simply sometimes because the patient needs a name for a disease or they need a code for the medical aid. But also for yourself, we are scientists. We want to confirm the diagnosis. Is this really allergy or not? If we, for instance, talk about asthma. Sometimes we want to dismiss a diagnosis because often patients have got to believe that it is definitely an allergy, especially food allergies, but the history is not indicative of that. So we want to do a test so that we can say, yes, it is, or yes, it isn't. We want to plan treatment. It's much easier if I can tell a patient that you are definitely allergic to X, Y, and Z, or this is definitely an allergic condition, and that is why you have to be compliant with your medication, especially if it is an indoor allergen in respiratory disease. Why do I need to use my intranasal steroid spray 365 days a year? Then I can show them why. And sometimes if the test is then negative, not to do unnecessarily avoidance. The disease progression and comorbidities. We all know that it is more difficult to treat your patients where the disease burden is higher. So a patient that has got only allergic rhinitis will be differently treated than a patient that has got atopic dermatitis, allergic rhinitis, and asthma. So the burden of disease is more, and those patients also often would be what we call multiple sensitized. They are not only allergic to one allergen, there are multiple allergens that we have to take in consideration and then plan the treatment accordingly, and also again motivate the patient to actually comply with the treatment, because that allergic inflammation, if uncontrolled, are going to cause comorbidities and complications. Allergic rhinitis progressing to asthma, we can't always predict, but if we do not protect the airways, it can definitely happen. Uncontrolled allergic rhinitis, allergic inflammation can cause nasal polyposis. although not all nasal polyposis are allergic. So it depends on the allergen that we find. And then precision medicine. I cannot offer a patient allergen immunotherapy desensitizing the patient toward an allergen if I don't know what they are allergic to and what the specific component would be. So let's start at the beginning. We've got a baby, 4-month-old, a girl with atopic dermatitis. So the history, this baby was born by C-section, a cesarean, was breastfed exclusively for the first 3 months, and then mom had to go back to work. So she supplemented with a cow's milk-based formula. Solids were introduced. Baby is 4 months old, so solids were introduced in at 4 months, and she opted for butternut. The mother has got allergic rhinitis. The father had atopic dermatitis as a child, but he's not symptomatic at the moment. They live in George. The house does have carpets in their bedrooms. There's no animals. And the house does have a problem with damp. The baby is healthy, never been on any form of medication in this 4 months. The rash on the skin did start about 3 months, mainly the cheeks and the neck. Thought that maybe it's just because of the dryness, because it's winter, heaters being used in the house, but the skin was actually even dry before the rash started. The last month, this baby really had disturbed sleep because she's irritable and she's scratching all the time, unhappy baby, and the mother doesn't know this child being like this. So should I test for allergies? Atopic dermatitis, we know, is mainly a skin barrier dysfunction. It's a skin disease. It's not primarily an allergic condition, but sensitization is possible. And if the baby is allergic to a food allergen and constantly being exposed to that allergen, it might cause exacerbation. So we do need to know what to avoid. We're not going to blandly just change milk if we do not know is there an allergic to the cow's milk protein. So avoid unnecessary avoidance. And also this mother is now starting to introduce solids. So which allergens can cause it? Everything that was in the mother's diet, because she was breastfeeding exclusively for the first 3 months and she's still breastfeeding. So everything mom eats, the baby is exposed to. So what are you now going to avoid? And what about house dust mite? It's also a possibility because in the first 6 months of a baby's life, they probably even more than that, but at least the first 6 months, that baby's indoors. They're not really venturing outside. So it's indoor allergens, and they're staying in George where it's damp and there's carpets in the house. So house dust mite is definitely a possibility. And the risk factors in this patient's history. Mom and dad has got an atopic tendency, and as I said, living in George with a house with carpets. So there's enough indicators that it might be an atopic child, and we do have some answers that we need to, questions that we need to get answers for to decide what we are going to avoid, not avoid, how do we go forth, and what are we going to treat with. So just a quick slide on, remember always with atopic dermatitis, house dust mite does play a role because the skin barrier dysfunction of atopic dermatitis, but your house dust mites release also a protease enzyme that will aggravate the skin barrier integrity being lost. And these dust mite allergens can now have a highway and a throughway through the epidermis to actually stimulate the immune response. And again, then a risk factor disease progression for asthma. So even we know in the asthma guidelines that immunotherapy for house dust mite is a treatment option. So be very careful for these high-risk patients with atopic family history, atopic dermatitis as a baby, and watch out for the house dust mite. What tests are we going to choose to do in this baby to sort this out? We can do skin prick tests. We can do a total IgE, a Fadiatop, which is a combination sifting test for all the inhalants, or we can do the FX5, which is a sifting test for children for foods. Or we can do specific RAS testing, an immunocap for a specific allergen that we say that we want to only do house dust mite and we only want to do this house dust mite. So it's more specific. So what are we going to choose for this baby? Now, my choice would be the house dust mites. We do need to test for tyrannicinis. We have got tyrannicinis and foreigni. So there is cross-reactivity between them, and D-tyrannicinis would be the main allergen that we find throughout our country. Blomia tropicalis is mostly at the coast. We do find it in Gauteng. Also, I've been living on the East Rand and practicing on the East Rand for 25 years. So we did see Blomia tropicalis there. But now this baby is living in George near the coast in a very damp area. So it would definitely be important. And it does not cross-react with the other two. So a dust mite mix or only tyrannicinis is going to miss Blomia tropicalis. We want to know, the mother would want to know, can she carry on with cow's milk allergy, protein-based formula? Because once the baby started being exposed to the cow's milk protein more in the formula milk, the symptoms did get aggravated. But now it's a goal. We are going to probably go to a soy-based milk. But what if there's cross-reaction? Because a certain percentage of patients will have cow's milk allergy and soya allergy. So test for it so that we can know, is it a safe option? Egg white is an important allergen driving atopic dermatitis. With the study that Professor Claudia Gray did in South African data, the most important allergens in atopic dermatitis was peanut allergy and egg white. Egg white allergy, with the integrity of the skin being compromised in atopic dermatitis, that allergen is also a risk factor for development of asthma later in this child. So we would want to know about that. Why would I not do the total IgE? It's not going to help me. It is of no significance if it is high or not. It's not going to change my treatment plan. It is a costly test, and it's not going to help me. My history already told me there's a risk for allergy, and this is a skin barrier dysfunction disease. If I do an FX5, the egg white, the soya, the cow's milk, and the peanut will be in there. And if it's positive, I still need to break it down. And then the Fadiatop, again, this baby is only 4 months old, so I am not going to expect a whole bunch of inhalant allergens. And I would then still want to know, if it is positive, is it now the house dust mite and is it Blomia tropicalis? And that would not make sense. I would rather do the specific allergens. Skin prick tests can be done in this baby, any age. We do it a lot of the time from 3 months older. You have to stop the antihistamines for 5 to 7 days. Skills are needed. Clear skin, obviously, if the arms are affected and the back, and we cannot use that, we won't be able to do that. The results are immediately available. So it's a mast cell degranulation. We test for the histamine response, and that's why the antihistamine has to be stopped. Just a list of all the first-generation antihistamines. And then the second-generation antihistamines. So a lot of the time, the patients would not realize that all these cough syrups also contain an antihistamine. So the next case carrying on in life, we're now up to 16-year-old. It's a boy. He has got a blocked nose and a postnasal drip. Since the age of 5-6 years, as a young child, he was treated with asthma, but it's not a problem now. It was probably a transient wheezer. Sneezing sometimes, but mostly a blocked nose. Mother's got allergic rhinitis. He never had atopic dermatitis or a food allergy. They live in Pretoria, carpets in the bedroom, a cat and a hamster in the house, and he loves his cricket. So what to test and how to test. Why do we test? Again, because we know this is allergic rhinitis. He's sneezing, he's got a blocked nose, he's got chronic inflammation. Because we need to know, is it only seasonal when he's sneezing? Most of the time he has got a postnasal drip. So is there an indoor allergen as well, stepping up and down the medication? And to give him quality of life, the option of allergen immunotherapy. But then I need to know, is he monosensitized? Is he allergic to more than one thing? What is the main allergen, which we cannot manipulate? Even if he is allergic to house dust mite, in a 16-year-old active sport-playing person, I would definitely go for allergen immunotherapy for grass if he is allergic to grass, because that I can do nothing. He has to breathe while he's on the cricket field, so I can't do that. He's too symptomatic to stop. So we can't stop the antihistamine because he won't really comply. 16 years of age, he is irritable. So we will do an immunocup. So we are going to do RAS testings. So we have to think about my expectation and the patient's expectations. So the history is clear. So they didn't come for that. They came to actually get something from me to make life better. So again, IgE is not going to help me. Photiotop is not going to help me because it is probably allergic rhinitis, but I need to know what is going to help me to predict his allergens. The house has got carpets in. He has got a postnasal drip most days, so we would want to know about house dust mite. Are we going to test for Blommy tropicalis in Pretoria? If cost is an option, it's probably not that important because that would not be the main one. It's unlikely to find Blommy tropicalis on its own in the northern part of the country. Both sensitizations, yes. In George, in the coast, we do find patients that are monosensitized to only Blommy, so we always have to test that. We do need to know about the grass. He plays cricket. He's out there. But we also need to know about the hamster and the cat. Risk prediction. Do we need to move the hamster out of the house or at least in an area where he is not breathing the allergen the whole night in his room? And we do the tree mix because we do want to know in the pre-spring season when the trees are starting to pollinate right now, do we have to step up the medication so that we have got good symptom control? So that would make sense in testing this child. They don't ever want to get rid of the pets, and it's not our aim. We're not cat killers or hamster killers. We just need to manage that and decrease the allergen exposure. And as I said, just move it to a place where there's good ventilation and have the vacuum cleaner with a HEPA filter. So our last case is a 25-year-old lady that had anaphylaxis. I saw her, this is a real case, and not just interesting to show out a few principles, but it is just such a fascinating case. So she had anaphylaxis a month ago, not once a month ago, when she was working in Amsterdam. So she's living in Plettenberg Bay, but she works for an international company and she had to go and work there. And there was a gala evening at the end of the conference. But that whole week, during lunchtime, when she's eating, and she's now a vegetarian, so it was mainly a diet containing legumes and fruit, she would feel this itchy symptoms in her mouth, but didn't think of it. On the night of the gala function, they danced, they had wine, and she had an anaphylactic reaction. She needed adrenaline. She was admitted to hospital. She's a healthy girl on no other medication. She's a runner. She's run marathons, she's a hiker, she often goes out in the mountains, and she never battled with allergies that bothered her, that she battled with. If she really thinks about it, she does often sneeze, especially in springtime. So she's sensitized to something, but which ones and what relevant allergens are we going to test? This is a little bit more difficult because there's, from the history, definite anaphylaxis. I got the letter from the treating physician from Amsterdam. There was a clear anaphylaxis, but what on earth caused it? What was in that meal? I even got everything and all the ingredients. Is absolutely incredible from the chef that prepared the dinner, the head chef that prepared the dinner for that gala function. So there was a whole bunch of things that she was exposed to. How can the history guide me this time? So we also know she's healthy. She's a trainer. She's a runner. So there was dancing involved, but there's also alcohol involved. So there's a condition that we call food-dependent exercise-induced anaphylaxis. So she can run. That's all good. And she can eat. That's all good. But if she exercise and eat a specific food component, food group, within 2 hours of exercising, it can cause anaphylaxis. And the cofactor would also then, on top of that, be that she did have alcohol. So the pollen food syndrome, we often see food allergies causing symptoms, mainly local symptoms, that itchy mouth, uncomfortable feeling that she had the whole week eating the lunch. So the patient is allergic to the inhalant, the pollen of the tree, mostly birch pollen, is the original allergen, the BETV1, that actually was implicated in pollen food syndrome. But there are a whole bunch of other inhaled allergens, pollen, that can also cause that, because she did eat the legumes and the fruit. So now I'm allergic to the birch tree pollen, and if I eat the apple, then my mouth started itching. She does have hay fever, and very, very mild and only seasonal, so again, pollen. She lives at the south coast in South Africa and now in the Netherlands. So what would be tested? So if I do a RAST, what am I going to choose? And if I'm going to choose, it's going to be very costly because it will be quite a panel. But then in one peanut, there are 9 different allergens, and I want to see pollen. I want to see in the birch tree pollen, is it the BETV1? So that is too complicated. So that is where a multiplex, a test that we do multiple components and whole allergens, so that we can see patterns, so that we can see, is this patient allergic to pollen and food that we can match, and then we can manage her and give her planning avoidance with that. And even then, if you eat these food groups, do not exercise within that time frame. So we call that the bottom up. So it's not the top down. We don't know. So we start at a flat bottom, a broad test, and we work up. You cannot test for MAC-wort on its own. And that was a sensitizing pollen. She was not allergic to birch tree pollen. So your pollen food syndrome has been implicated there as well. The lipid transfer proteins is one of the components that you make an IgE antibody toward, and that some of these components are a little bit, let's call them promiscuous. They're all around in nature. It's not only the MAC-wort or only the apple, they share an allergen. And we also know about the MAC-wort celery spice syndrome. Everything that was used to dolly up at a gala functions meals. She was positive to apple also, negative to the peanut, nuts, and seeds. So we can give her some indication of what is happening in her life. So in summary, the history is the most helpful because it's wonderful what we have got to test and the different testing. And allergology is such a dynamic field. We learn all the time about patterns, but we need to know what to test. If it is only allergic rhinitis and asthma, it's what we inhale. And we do that to plan treatment and do avoidance with house dust mite and those things. Remember, house dust mite in atopic dermatitis, in pollen food syndrome, anaphylaxis, we often would need the components. Some of the components, for instance, if you are thinking about peanut, you can do the Aura-H2 on its own to do risk prediction, to give that mother an indication. This is the one that is positive because the patient is also allergic to grass, because then the peanut, the one component can be, your CCD can be positive, so your whole peanut test RAST for peanut, if you ask it that way, it will be positive. But now the child or this young man that we had playing cricket is allergic to grass, and then the peanut will show up false positive. So there we can do the component. The same with grass pollen in that child. The risk is that if we do only whole allergens and we don't do the components, he's going to be told that he is allergic to wheat and he can't have his bread anymore. But we can test the wheat that we eat, the omega-5 gliadin. We can do that, and we can do the CCD, and I can tell him that you are grass allergic, go and have your peanut butter sandwich, it's all good. If it's insect venom, we do need the components also, and you can do them separately. You don't have to do a whole panel of 290 components, but we do need the components to plan the allergen immunotherapy to desensitize for your bee venom allergic patient, because we need to know that the serum that we are using to do the desensitizing, does it contain the component that this patient is allergic to? Otherwise, we're wasting a lot of money importing allergen immunotherapy from Spain, put this patient on a 3-year course of treatment, and the component isn't present in that specific reagent. So let's keep our allergic patients running. Let's test them sensibly and give them good advice. Thank you very much.
Thank you, Dr. Corley. I'm going to hand over now to Dr. Louise to start her presentation. Thank you, Dr. Louise.
Thank you, Janvi. We'll just look at allergy testing, the basics and beyond. So allergies are increasing worldwide. About a quarter of adults have seasonal allergy, and 7% have eczema, and 6% have food allergy. And then allergies are an abnormal immune response to a harmless stimuli. And laboratory testing is useful for diagnosis and treatment. And just looking at the immune system, you can get immune deficiency where the immune system is not fighting effectively, autoimmunity where the immune system is fighting its own, or allergy where the immune system is fighting harmless substances, or autoinflammation where the immune system is overreacting. Then just looking at why do we develop an allergy. So there's a dysbiosis, which can be due to genetic factors, epigenetic factors in children, environmental factors, for example, exposure to drugs, maternal microbiome, and mode of delivery. And this dysbiosis causes a dysregulation in the T regulatory cells differentiation. So there's an imbalance between the Th2 cells and the T regulatory cells. And the food antigens and bacteria also causes the T follicular help cells to increase the B cell production and increase IgE production under the influence of interleukin 4 and 12. And this causes then allergic disease. Then just looking at the new classification from EARCI, which was in 2023. So there's now, so it's type 1, 2, 3, 4, A, B, C, and then type 5, 6, and 7. But we will just focus on type 1. So in type 1, we have the allergen is exposed to the epithelial cells in the skin and the lung and the gut. And then the dendritic cell goes to the lymph node where the antigen is exposed to the naive T cells and the Th2 cell response is activated. And then that is under the influence of interleukin 4 and 21. These cells cross-switch to plasma cells, then they increase the IgE antibody production. The IgE antibodies binds to the basophils and the mast cells, and then on subsequent exposure by the allergen binds to the IgE that is and causes cross-linkage, and the mast cell releases the mediators, for example, antihistamine and tryptase, and then other cytokines and leukotrienes. Just looking at this picture, so just to simplify it, it's when the patient is exposed to the allergen, the plasma cells produces the IgE antibody. The IgE antibody binds to the mast cell, and then on subsequent exposure to the allergen, the allergen binds to the IgE antibody, and then we get release of the mediators. And these cause then the allergy symptoms, the mediators, histamine, and the different other cytokines. For example, conjunctivitis, rhinitis, the oral allergy syndrome, angioedema, asthma, anaphylaxis, and urticaria or dermatitis. So just looking at what is the different terminology for allergy versus sensitization. So if we have a positive IgE test and the patient experiences symptoms, that means that the allergen has bound to the IgE receptor on the mast cell and the mediators has been released, for example, the histamine. But if we do have a positive IgE test, but the patient does not experience any symptoms when exposed to this allergen, we say that the patient is only sensitized and not allergic. Just looking at what is atopy. So atopy is a personal or family tendency to become sensitized and produce IgE antibodies in response to ordinary exposure to allergens. So if your mom is allergic, there's a 30% chance that the kids will be allergic. But if both parents are allergic, there is 60% chance that the kids will be allergic. So the family history is very crucial. Then just looking at allergen burden. So it is important to know all the allergens that a patient is allergic to. For example, if the patient is allergic to cats and dogs, but the patient does not experience any symptoms, and then it's the grass pollen season, the patient exposed to pollens, the patient crosses the symptom threshold. So if we can lower the allergen load of the cat and the dog exposure and the pollen exposure, we can push the patient below the symptom threshold again. Just how to diagnose. So like Dr. Cordy-Loader explained, is always the history is crucial, examination, and then we have skin prick testing that can be done, blood IgE testing, and then basophil activation testing or lymphocyte stimulation testing, which is more the non-IgE testing, and then provocation testing. So we won't go into the food history, allergy history at this stage, but it's important to look at the specific allergy symptoms, the onset, the cause, the seasonality, aggravating and relieving factors, and then drug and food sensitivities and other medical conditions, medication use, and then home environment and social history and family history. And just looking at blood IgE testing, so there are different options available in IgE testing. We have specific IgE testing, which is the immunocap testing, and then mixed allergen testing, which you have a food mix, which is also known as the FX5, and if it's positive, a breakdown should be done. And then we have the inhalant mixed IgE, which is also known as the Phodiotop, and if it's positive, a breakdown should be done. Then we have the precision allergy molecular diagnostic application, or molecular allergy or component resolved diagnostics, which is all the same term for the same type of testing, where we have the single test, for example, the ovomucoid, or multiplex testing, for example, the Alex or the Isaac. So if your food mix IgE is positive, a breakdown should be done, and this then includes the egg white, cow's milk, wheat, fish, soya, and peanut. And with the inhalant mix or the Phototrop, if it's positive, the breakdown then includes the house dust mites, which is Trinesias and Blumia tropicalis, and then grass pollens, the Bermuda and rye, mold, Alternaria and Aspergillus, cat and dog, and then the tree pollens have been added, the plane and cypress tree pollens. They are not currently on our panel, but we are going to implement them. Then, if the history suggests a specific allergen, for example, the avocado or insect venom, then that specific allergen can be done. But if the patient is multi-sensitized, or if you're not exactly sure which allergen could be the culprit, the Alex or the multiplex comprehensive IgE testing can be done, which then includes almost 300 food, inhalant, latex, and insect venom allergens in one test. So this is just actually another representation of the new 9 allergens according to the South African Allergic Rhinitis Working Group, which is the Bermuda grass, the ryegrass, the Alternaria, and Aspergillus, Blumia tropicalis, and the Trinesias, cat and dog, and then the plane tree and the cypress tree pollen. So just looking at our requisition form, we have the skin prick testing in that area. So skin prick testing can be done. The advantages is rapid and cost effective. The disadvantages is there's a limited number of allergens that can be tested. It's influenced by antihistamine use. There's a risk of anaphylaxis, and skin disorders precludes its use, for example, with eczema. And then there's a degree of subjectivity. And then just looking on specific IgE testing, so we have also the Phototrop on top there for inhalant allergens, which could be then done on its own or with a breakdown. And then there's also pollen and tree mix IgE testing available. Then we have the food mix as well, where you can do the food mix on its own or with a breakdown. We also have the nut mix and seafood mix and a different other IgE testing available. So what are the specific IgE testing? The advantages: it's safe and it's rapid. It's not influenced by antihistamine use, and screening panels are available. The disadvantages: you can have false positive testing where, for example, the cross-reactive carbohydrate determinant or the CCD causes the extract to be positive, but we will go into this a bit later. And then there's no resolution for cross-reactivities, and negative results does not exclude an allergies. It could also be a non-IgE test allergy. Then just to look at where our Alex is available on our requisition form. So what is molecular allergy diagnostics? So we have looked at the different names, so precision allergy molecular diagnostics or the allergy component testing. It measures the IgE to specific allergen molecular components for diagnosis, risk assessment, and personalized management. So if you look at what specific IgE allergen testing, the whole allergen extract. For example, this is the normal dog IgE extract, and it is a mixture of all the allergenic and the non-allergenic proteins available. But if you look at the single molecular allergens, we have different specific proteins or components for the specific dog, which is broken down into the specific dog components. They have different functions and they have different clinical utility. So, for example, the KNF1 is a marker of true dog sensitization and can be used as a marker for allergen immunotherapy. And the KNF2 as well is also a true dog marker of true dog sensitization. Another one that's quite interesting is the KNF5, which is a major allergen in male dogs only. So if the patient is only positive to the KNF5, he or she would possibly tolerate a female dog as a pet. Then just looking at the allergen nomenclature, so the WHO and the IUIS subcommittee stated aim is to standardize the names given to the allergens that caused IgE-mediated allergies in humans. So, for example, for peanut, we have the Aricus habegia, which is the genus and the species, and then 2 is the order of discovery. So all allergens have their specific names. So what are cross-reactive components? So molecular allergens can be divided into specific and cross-reactive allergens. Cross-reactive components are protein families that are shared amongst distantly related allergen sources. So, for example, the LTP amongst plant species and the lipocolins amongst animal species. Then also the cross-reactive components and the risk of severe systemic reactions. So, for example, the cross-reactive carbohydrate determinant does not normally cause any clinical reactions. But the profilins and the PR10 proteins, which are more heat labile, can cause your oral allergy syndrome or oral allergy symptoms. And then the lipid transfer protein or the storage proteins are your more stable proteins, and they normally cause severe allergic reactions. So just looking at this example, if we have a peanut IgE extract that is positive, there can be 3 different clinical scenarios. If the patient doesn't experience any symptoms when he eats his peanut and we do the molecular testing and all the components for the peanut is negative, the RH1, 2, 3, 9, and 8, this IgE extract is then positive due to the CCD that's present in the IgE extract. But if the patient, when he consumes his peanut, he has a bit of oral allergy symptoms, and we do the molecular components, and we see, okay, so the RH8 is positive. It is a PR10, and because it's less heat, it's more heat labile, the patient does not experience systemic symptoms. If we then move on to the patient that does experience symptoms when he eats the peanuts, and we look at the molecular components, which is then positive, the RH1, 2, 3, which is storage proteins, and LTP, the RH9, which are very heat stable. And this patient is then highly allergic and should avoid all peanut products. So just to illustrate this case as well, normally then we get the results of a soya IgE that's positive, the wheat is positive, and peanut is positive. But also the grasses are positive, and the rye grass is also positive on the extracts. And if we then do the molecular components, we can see that all the molecular components of the peanut and the soy and the wheat is negative. So this patient can then still continue consuming his soya, wheat, and peanut, but he's allergic to grasses. Another cross-reactive component that we can look at is LTP. So here the wheat is positive and the peanut is positive on the extract. But if we look at the specific molecular components, the RH9 is positive for the peanut, and the wheat, the tri-A14 is positive, which are LTPs. And there are also then different LTPs present in different fruits. For example, the apple here, the kiwi, celery, grapes, and maize is positive. And this patient can then be allergic to all these products, and this should be clinically excluded. Then just looking at the clinical utility of allergy component testing. So it's to avoid uninformed dietary advice, to identify allergens associated with severe symptoms, to identify children likely to grow a food allergy, to improve patient selection for allergen immunotherapy, and to provide appropriate guidance on pet selection, detection of allergy syndromes, distinguish between cross and co-sensitization, and investigate anaphylaxis where the triggering allergen is unknown. So just for example, avoid uninformed dietary advice. So if your milk extract is positive and we do the component testing and we see that the BOS-D4 only is positive, which is the alpha-lactalbumin, it is heat labeled, so the patient would be able to eat his milk in baked products. But if the patient is positive on the milk extract, but we test the component testing, and here the BOS-D8 or the casein is positive, which is heat stable, the patient will not be able to eat his baked milk products, for example, muffins. Then another one is the tomato PR10 is positive, so the patient would not be able to eat fresh tomatoes, but because it's heat label, possibly the patient would be able to eat tomatoes in a baked sauce. And then the apple LTP, if it's positive, it is mostly concentrated in the peel, so it would be possible that the patient could eat the apple if the apple is peeled, but this should also be clinically determined. Then just looking at identifying the allergens associated with severe symptoms. So if we look at milk, like we said, it was the BOS-D8, and egg is the GALD1 or the ovomucoid. And then peanuts is the storage proteins of the LTP. The normal one that we test is the ROH2, which is a storage protein as well, but there are other storage proteins. And if they are positive, they are very heat stable, and the patient is less likely to outgrow allergies and causes severe symptoms as well. So just looking at patient selection for allergen immunotherapy, if the bee venom IgE is positive, and we do the extracts of the bee venom, and the patient does not experience any symptoms when stung by a bee, then and the APM1 and the APM10 is then negative, we know that this patient is not allergic to bees, and it is the CCD that's causing the IgE extract to be positive. But if the patient does experience symptoms when stung by a bee, and we test the components and they are positive for the APM1 and APM10, the patient is more, it is then a true bee venom allergy, and the patient is eligible for allergen immunotherapy. Just to note as well that the APM10 is not as well represented in the allergen immunotherapy available, and it could be something just to keep in mind. And then the true wasp allergy can be then defined when the VESV1 or the VESV5 is positive when we do component testing, and the patient then also experiences symptoms when stung by a wasp. So that like we've said now, so guidance on pet selection. So if the KNF5 is positive, it would be the patient would be able to tolerate a female dog as a pet. So we offer the Allergy, the multiplex IgE testing. It's a macroscopic array. 0.5 moles of serum is needed. It tests 295 allergens, and it's got a CCD blocking in the test available. It includes food, inhalants, latex, insect venom, and cross-reactive components. And there is a very nice interpretive report as well. So just having a case illustration of the Allergy. So you get a nice summary of the detectable sensitizations, the negative allergens, and then the positive ones. And in this patient, then the house dust mite was positive. And it was a tropomycin. Just to explain here, that the dot means that it's a component, and the multi-dots here means it's an extract. In this patient, then the Blomia tropicalis was also positive, which was also tropomycin, and in the cockroach, the same component, cross-reactive component. And the tropomycin is then also present in shrimps and prawns, and the herring worm or the Anisakis simplex also has tropomycin present. We can also see in this patient, which is a little bit uncommon, they was he was also sensitized to fish, which is different from shellfish. So in the house dust mite, shrimp and cockroaches share a cross-reactive component, protein called the tropomyosin. And this tropomyosin is a heat-stable protein, and it can be inhaled or ingested. And patients can develop severe allergic reactions to shellfish and seafood vapors. And the house dust mite allergen immunotherapy is not always effective. Here's another example of the report. So take-home message. The allergen component testing is useful to distinguish true primary sensitization, clinically relevant cross-reactivity, clinically irrelevant cross-sensitization, and it's especially useful in patients with complex symptoms and polysensitization.